With the hot Boston summer underway, I went up to our main campus in Cambridge to meet up with a friend and colleague, Dr. Galucci, the head of the Department of Restorative Dentistry and Biomaterial Sciences at Harvard School of Dental Medicine. Dr. Galucci is a world-renowned prosthodontist and implantologist. We met in the Harvard Yard on a warm, balmy day this summer.
Dr. Galucci, thank you so much for joining me. Let's talk about Endo Crowns, which is an area you've been experimenting with now, and there's a lot in the literature that is supporting it, and I wanted to kind of join you to have you talk to me a little bit about, first of all, what is an endo crown, indication, contraindications, and maybe share a couple of cases.
Sure, absolutely. Well, you know, an endo crown is basically a way of restoring the missing coronal part of the tooth without the need of doing a post and core. So basically what we use is we design the crown with the well-defined margins and all that, and we use the pulp chamber as a way of
increasing the surface area.
Increasing the surface areas added to the crown. So basically it's just one piece that is adhesively retained or bonded to the tooth.
Right. First of all, the material of an endo crown, does it make a difference? What are the good ones? What are the things to avoid?
Well, I mean, obviously you need to think that we're going to be relying on an adhesive technique. So basically bonding to the tooth side and bonding to the material side is paramount for success. I like to use what we call an etchable ceramic. So there are two main categories. There are many, but non-etchable and etchable ceramics, and I in particular like to use lithium disilicate, very appropriate for various reasons: resistant, etchability, strength, and also translucency and aesthetic characteristics that you may need for these restorations.
Right. You know, and me as an endodontist, you know, an endo crown is a one-piece type of a structure, right? It means that the main part of it is going to be fairly thick amount of this material. So, you know, my concern is if a tooth ever needs to have a revision, drilling through these materials ends up being a little bit more of a challenge. So what are things that you would recommend not an endo crown to be made out of so that it could avoid these kinds of problems? I would probably say zirconia.
Well, I mean, yeah, avoid zirconia for sure, but you know, you need to think in this way. IMAX is the material mechanically, the most mechanically similar to enamel, right? So even when you take an X-ray, an IMAX restoration looks like the contralateral tooth. So that's number one. So let's say that the endo crown is cemented, is bonded and all that. You have no problem drilling through the material. What is going to be difficult is to be oriented on the direction, because that is now in the chamber. So that's why I always recommend that at the very bottom of the pulp chamber that you leave another type of restorative material that is indicating that you're arriving to that point.
Interesting. So like a different cement color contrast to...
Exactly. Wherever you use regularly to, you know, obturate that aligner, exactly like that. But when you think that, imagine that the same is the case for retreating a tooth that has a post and core.
Right.
And sometimes it's much more challenging. Sometimes those post and core, they come out very easily, but if not, you spend a significant amount of time trying to remove them. Here, I believe that you still have access if you don't use a very strong material like zirconia. Lithium disilicate, we have now some hybrid composite restorations. I see no problem in terms of accessing, but I would assume, I'm not an endodontist, but that the orientation may be a factor here for if the endodontist needs to get back in there.
I think for all good endodontists, the access to and through these teeth is not so much looking at the crown, because that's obviously been modified to match the shape that the prosthodontist, the restorative dentist wants it to be, but rather to emphasize and focus on the area of the CEJ of the tooth itself. So we always try to focus and triangulate the area of the CEJ where the root is, because that's where we're going to want to aim for. That's basically what we're going to be looking at. But can you tell me what are the advantages versus disadvantages of an endo crown crown compared to just going with a conventional core buildup and a crown? When do we want to use an endo crown?
Yeah, I mean, I obviously the traditional approach would be to have a post and core and a regular crown. So my window of indication are in those cases where you start questioning the retention of a regular crown by a natural core or remaining structure of the tooth, and you start bringing in the picture of a post and core. Or the upper limit is those cases where you would say, well, you know, I have no retention at all, I'm going to take the tooth out and place an implant, especially in young patients. I mean, I do implant dentistry, and that's the main bulk, and I learned that it would be nice to somehow prolong the life of a tooth with this strategy. And this is where I see the indication of endo crown. Not being very aggressive with the post and core, preserve the very limited amount of tooth structure that we have, and use the strength of adhesive dentistry to prolong the life of a tooth until it's time for the implant.
Yeah, I mean, and that's a great point. And you, as a world-renowned implant expert, the fact that you are so focused and interested in keeping the teeth and preserving teeth is itself an indication as to how much value you put into our own natural dentition, and that's really important. And I think that's a great point about trying to delay the ultimate tooth loss, because I always say healthcare, is a saying in medicine that healthcare is the slowest way to die, and dentistry is the slowest way to lose your teeth.
You're so right. I mean, everything we do in dentistry has a life cycle.
Right.
And if you look at the literature, a life cycle of a crown is 10 to 15 years. Life cycle of endodontically treated tooth, and life cycle of an implant. We know now that implants, they are an amazing solution, but they're not complication-free, especially at the long term. So what I'm thinking now is that how I can develop treatment strategies for those patients, especially young patients, that I can aim for the whole span of the patient's life with different life cycles of treatment.
Right.
And I think that, without being heroic, the endo crown comes into that sequence of long-term thinking in between the conventional dentistry and the future implant that I see in these cases.
No, you're absolutely right. Essentially, it's all about managing risk sequentially until the risk of losing the tooth is far greater than that of the alternative. And so it's a wonderful way of looking in treatment planning cases by having this type of priority in mind. So let's talk about a case that you wanted to share, and so that you can kind of put this in perspective.
Well, that case is the reason we're here, because I sent the patient to you, and the patient had a large restoration bicuspid. It was deemed to be non-vital. I took an x-ray, I saw a big decay, recurrent decay under the restoration, and I can already anticipate what it will be a remaining tooth structure after removing decay and all that. So I called you and I said, Ali, let's do a root canal, no post preparation. And my rationale here was that this was a very small tooth with a very short interocclusal space. Similar to the case that we will discuss later, what I thought here is that after preparation of the tooth, removing decay, if I need to remove more tooth structure inside the canal for my post and core and start building up, then the space for my crown will be reduced or limited, And this is something that people don't discuss much, but sometimes we do beautiful post and cores, but then we end up doing metal tabletops or lingual metal construction because there is no room for the restoration. So here the advantage of the endo crown is that once you do your preparation, and after we got the root canal back, what I will do is I prepare the tooth like a crown. I had like a very nice 2-3 millimeter ferrule on the mesial, lingual and buccal aspect, but the distal was just flat. And then I create the path of insertion, and then that crown will be now having the adhesive surfaces on the outside and the margin of the preparation, plus the pulp chamber 2/3 superior of the pulp chamber. And then I apply an adhesive technique, and then now, as you can see in the X-ray, it looks like a continue of the tooth.
That's actually what triggered this whole concept of talking to you about endo crowns, because I think most people would refer a case like that to me would then require a post space, and they say, let's do a post and a core and a crown, whereas when I saw that you were able to do an endo crown and get away with it, I think that's really a great service to the patient, because it's in many ways minimally invasive, but the trick is going to be on the adhesion side, which we're going to talk about.
Let me ask you a question. So when you finish the root canal, what is your preferred material to seal on top of the entrance of the canal?
Yeah, so actually what I usually like to do is I like to do some immediate sealing with a dual cure resin ionomer material as some type of a liner. I use BC liner, which is blue liner that is used in combination and optimized to work with the calcium silicate cements that we use for the obturation. And then as you mentioned also, what's nice is it allows anyone later on who wants to do a revision or anything needed to be able to find that's where the access is.
That's important that you do the immediate dental sealing at that type.
It improves the coronal seal immediately as well.
And that is amazing for the endo crown as well, because they will improve the adhesion on that area as well. For endodontists, if you were to do that, and you know that the restorative dentist will do an endo crown, the idea would be like if you take the whole height of the chamber and your material will occupy the inferior third, and leave the 2/3 in a non-retentive way. You know, that would be exactly
what you would want to do for that.
What I would like to see for now.
So what I do usually also is that I may fill up all the way up to the chamber, filled with that blue material, but because it's blue, it allows the restorative dentist to be able to drill it out and create the shape that they want, and that way they will be able to, then that kind of goes away from the traditional idea of using cotton on cavit, where the cavit could fall out or the cotton could get contaminated, and so it gives many different options. So this was a great case. I think the handling was perfect. Just a quick thing before we sit down and talk about the next case. What are the contraindications for endo crowns? When would you not use an endo crown?
The main contraindication of an endo crown would be when the patient had a previous post. Although you could think of reseal that canal and doing all that. And I would be very reluctant to do an endo crown when I can assess the quality of the dentin is very poor quality, sclerotic, change of color, and where I know the adhesion will not be as effective as I can. In which case, you know, you start bringing up the next level up, is that tooth restorable, you know, like I think that's where the limitation of that is. But pretty much I also like the fact that it's a monolithic restoration, it's one piece. Just as I said, there is endo crowns are a new way of learning what we have been doing for centuries, and you know how difficult sometimes is, but the fact that we know now how to adhesively bond those things to the tooth, it brings the advantage that the space constraints are no longer there. You know, basically you're giving the tooth back what is missing in one single piece. There are no layers after layers and that. So I think that, you know, the evidence out there is, I know there are cases, you know, for more than 20 years, and especially in Europe, in Germany, they were doing that. They started with CEREC more than 30 years ago to do endo crowns, but the materials we were using then, they were not very good for the adhesion. I think now with the new materials, this is something that it should be revisited and implemented. People will have a lot of satisfaction with it.
Yeah, I mean, and is this also more efficient in terms of just the process of making the crown, or is it, would you say it's almost the same?
It's a two-visit approach. First visit, you prep and temp and impression, and the second visit you do the adhesive part and bonding of the restoration. So it's a very simple procedure. You may be interested in the temporarization of the crown. We normally do it as a regular acrylic temp. They do not tend to stay as nice as the other one. You need to kind of
bond it.
No bonding, but they're different. So I like to use as a first option non-eugenol temp bond.
Provisional,
yeah. That's important because
The
eugenol affects the bonding. But if that doesn't stay, what you can do is there's another technique which is a spot etching. You know, a spot etching is as you pick one area of the tooth, you acid etch, put a little layer of bonding, and that is enough to
hold it provisionally.
What is critical on these endo crowns is that you need to have synchronization with the lab. The lab needs to know that the impression is coming next week, so the patient doesn't go on the temporary for months and months. You know, so it's you want to shorten the temporary session.
Because the indications are usually those kinds of cases. So terrific. And I think what you mentioned also about the eugenol is important because it should be coordinated with the endodontist, because a lot of endodontists also use zinc oxide eugenol-based cements, and that could help cause the problem.
Yeah.
So terrific. Let's go sit down somewhere a little bit quieter with people passing by, and so we can talk about the second case.
Sure.
Awesome. Let's go. Dr. Galucci, what about that second case that you got?
Well, that's an interesting story. I mean, that's a patient that had an old crown, and the natural core of the preparation broke. So the patient came to see me. I made quickly a temporary, and we were hesitating to, you know, plan for an implant. The patient wasn't really sure about that. So I did a quick temporary, and the patient goes on a business trip, and the dentist abroad, when the crown fell off, he used a resin bonding cement on my acrylic temp. And the patient came back and I couldn't really remove it, you know. So that was kind of like a good test. So then we discussed with the patient, the root canal was done. We waited, you know, a little bit of time to kind of make sure that the root canal was successful. And then I did an endo crown preparation, and I learned two things with this particular case. Number one, the patient had a beautiful ring of tooth structure with some enamel in it, had a large chamber that I used for the design of the endo crown, but in particular, he had a deep bite. In those cases with a deep bite, when you need to plan for a post and core and a crown, you very often either run out of space on the palatal, or you end up with a crown that is too bulky because you need to compensate with those thickness. And I thought that it was the right decision to make an endo crown there because it's just one unit.
So in these kinds of cases, occlusion would be a big factor, right? So when you have an overbite, then how do you make sure that the incisive guidance is not going to be a problem for these types of patients?
Yeah, well, normally you lighten up a little bit the excursion of the mandible on the endo crown, and you kind of rely on the adjacent teeth. Obviously, these are in function, and you expect to the tooth to be function, but you know, we rely on the adhesive protocol in these things, and we have made a long way in generating knowledge on adhesive dentistry.
Yeah, that seems to be, from what I've learned from the first case and now this, is that the limiting function of an endo crown is the internal type of kind of friction-based retention, and then the quality of the adhesive dentistry.
Yeah, so basically I think that we are not relying on any type of form of retention. We are really trying to get a good fit, so there's no rocking. This is what, you know, I look before cementation, but the mechanism by which the endo crown remains attached to the tooth is
purely adhesive.
Purely adhesive. And the way we like to carve inside the pulp chamber is to increase the adhesive surface, not to provide some retention on the tooth. So basically, the key parameters are to have a ring of enamel if you can, at least 360, 3/4 it's okay. We know the adhesion to enamel is much more efficient than dentin, and you know, we are now also learning more about adhesion inside the canal, which is a different topic. There's a lot of research going on that. But basically, it's mostly to increase the adhesive surface than to provide a form of retention.
That's interesting. So we're not relying on any mechanical components. It's just purely the chemical bond to the dentin. And as you said, you know, I agree, because the dentin quality inside the tooth is, and the frication, if you're dealing with a molar, it's very different, because adhesive dentistry relies on dental tubules, and you're dealing with a whole different histology of dentin inside the tooth than you do outside. Furthermore, as we do endo and we use a lot of hypochlorite, that changes throughout the procedure of the chemomechanical instrumentation. Do you have any recommendations for, you know, after endo, maybe resurfacing the internal surface by removing it a little bit?
Yeah, so the type of materials that is being used during the endodontic treatment, it affects the quality of the adhesion, and I recommend that we need to first get a good quality endodontics, and the endodontic treatment should not be altered in lieu of having a better adhesion. In any case, the intraradicular adhesion is not the one that we rely the most. We rely the most on the outside portion, dentin and enamel. But what is important in there is, as you mentioned, is obviously we'd like to keep a small layer on top of the entrance of the canal with any restorative material that could be the same one used after the endodontic treatment, and then resurface the walls of the pulp chamber. You know, well, we know that the immediate dentin sealing, particularly in vital tooth, is important. And a non-vital tooth is less relevant, but you do want to resurface before cementation, that without changing the shape, of course, of the preparation.
And also we know that the sodium hypochlorite does remove the protein component part of dentin, so this kind of resurface is important. Do you also think that maybe using some type of sandblasting or anything beyond just etching with an acid would be helpful at all inside the canal?
If you sandblasting it will be efficient if you have some sort of resin, you know, like underlying composite or something that. But as I said, I see mostly that intra-chamber adhesion not principally as having a retention function, but more of a sealing function, you know. So I'm relying mostly on the outside of
for your adhesion primarily.
For the stability. Another element that I think is important is by creating it, and you should see in the Endo Crown here, when you look at the picture, it almost has like a protuberance, you know, like it's the opposite of a post and core, you know, which brings the question, you say, that post and core, we question the adhesion of an Endo Crown, but that post and core also needs to be supported by some sort of
adhesion,
adhesion, retention. So it's kind of like thinking on the same process but in a reverse way.
Yeah, it is. I mean, this is a very interesting way to look at the problem we're trying to solve, because historically we used to say that, you know, if your post and core comes out with a crown, you know, those are not the right things to make the crown. But the endo crown is very different in terms of understanding the mechanics of it. Do you think a core that goes deep inside the tooth could be misconstrued as a short post that could have potential cracking and internal force functions, or the design of the crown and combination could help alleviate some of that shorter post looking component of the core?
If you think in terms of post and core, I mean, we are not going beyond the chamber, so we are not engaging in any portion of the canal itself. Well, it would be hard to differentiate with in a mono radicular tooth, you know, but it's very short, and as I said, it does two things. It allows for repositioning the crown in the right position, and avoids rotation and increase adhesive surface on that area a little bit.
Exactly. But it does really come down to adhesion versus luting, right? Because essentially previously, if you had a short core or a short post that could be kind of almost the same length as these types of endo crowns in some cases, you know, the torquing and shear forces could then create crack lines right around the cervical area of the tooth, as we see with these short posts oftentimes, that they don't distribute the force too far down the canal. But I think the distinction there, as you said, is the difference between bonding versus luting, which will then be very different.
We also need to put this into the context of treatment planning for these cases, right? As I said, most of these endo crown cases come to the question whether the tooth needs to be extracted and do an implant or redo a post and core and crown. You see what I mean?
Right.
So it's not like these endo crown cases are like the default choice for all the cases, you know. So nowadays I think that if you have particular molar sites or bigger sites, this is cases a central incisor, but where you have a lot of tooth structure, I wouldn't even choose a crown as a first option. I would go with a tabletop onlay, seal the pulp with the chamber with the composite, and then glue everything on top, you know.
Right.
So that's what we are coming in. The philosophy here, Ali, is that in order to restore the missing elements of the tooth, I realized over the years that we need to stop thinking on subtractive techniques.
Right.
You know, because you can imagine, do you know how much of the tooth structure, of a sound tooth structure, you lose when you prep for a crown?
It's probably 60% or not or more, right?
40%. There's a beautiful study that they did. They took intact teeth, they prepped them, and then they weighed the tooth before and after preparation. So then by
oh, you're talking about the full tooth, including the root.
Yes.
Right. Not just of the crown.
Just the full tooth. Right. So this was an in vitro study. They removed.
Yeah, that's amazing.
You know, 40%
of the whole tooth. That's
of the whole tooth weight.
Wow.
Is removed when you do a crown. And I see these endo crowns on teeth that they have been affected by, you know, a large decay or a recurrent decay underneath a composite that, you know, as a way of minimally invasive restoration. All I need to do is just, you know, resurface my prep, retouch my prep, and make sure that, you know, inside the chamber I have no retentive area. So it's.
I think all of this kind of leads to this whole bigger component of what you just said, it's subtractive versus the additive dentistry. And I think that's really where things are moving, with everyone trying to be more minimally invasive and reducing less of the tooth structure. Perhaps the next, maybe we can meet up again and we can talk more about, you know, additive techniques that are now being added in terms of just even chairside clinical composites versus even doing these cast onlays or milled.
Well, we are doing prepless veneers now, and a lot of things that it doesn't involve admixtures. Now, it is important that we mentioned that a little bit in the previous case, but the type of material chosen for these endo crowns is critical. Although people are demonstrated and saying that you can bond to zirconia, I do all these crowns in lithium disilicate because I know the adhesion there is way superior, you know. And the way you treat both surfaces is not just the tooth, but the way you treat the surface on the ceramic is as important as the surface on the tooth. I mean, people, the colleagues, they just look at the tooth, but the intaglio of that endo crown, the way you treat that, is critical. You know, normally we use hydrofluoridic acid for 20 seconds, no more than that. They need to be rinsed off with alcohol, ideally in the ultrasound bath for 5 minutes to eliminate the debris. Apply silane, allow the silane to evaporate, and then, you know, and the tooth gets acid edge, so that's kind of the preparation, two surface preparation, and they're very distinctive. You know, one is phosphoric acid, the other one is hydrofluoridic acid for 20 seconds, and then you apply the bonding in both surfaces. And what they use here is the other secret of the technique. I don't use any adhesive cement, I use regular composite. You know, you can see on the x-ray that there is a little white line, radio opaque line. So what I do, I take the packable composite, the regular one that I use, with my fingers. No, I don't. Yeah, you can heat it up, but with my fingers I make like a small layer. I put it on the crown, soften it a little bit with the Optibond, and I press until there's
almost relining it until you.
Well, I mean, I don't take it out. I keep pressing when there's no more cement coming out.
Yeah.
Only at that point I dilute it. If you use any lighter body cement, like a flowable composite or an adhesive cement, what happens is that you press, and the moment you release, there is a vacuum, and then you start having bubbles in there. You know, that's why the advantage of using a packable composite, it makes a significant difference in the outcome of the bonding.
Yeah, and you probably get a much harder bond strength by having a real composite as opposed to a flowable or just a bonding material in there. So that's your bonding technique. Just to kind of sum it up, for preparing the surface, phosphoric acid, you try to focus making sure you have enough enamel, right? Yeah. How long do you do your enamel bonding versus dentin bonding, the standard?
It's about 30 seconds.
30 seconds. Yeah. And then the bonding agent, do you feel like a bonding agent, any of the generational difference between any of the bonding agents that you use?
Yes, they're different. I like to use OptiBond because it's what we call like a charge bonding. It has some, it's a little bit more mechanically stronger than, but when we apply the bonding in both surfaces, it should not be cured. You know, it's all cured at the end. Right.
The bonding agent is cured along with the
composite, because if you cure the bonding agent,
it gets thicker.
It doesn't fit anymore.
There you go. Okay.
You know, so you acid etch the tooth, you acid etch the intaglio of the crown, right? Then you apply the bonding of the tooth.
So it's a dual cure bonding agent then, right?
No, it's a light curing.
Just a light curing.
Yeah. So you apply the bonding on the tooth, you apply the bonding on the intaglio of the crown, and then you take the packable composite that you thin it out very, very thin, and you apply more OptiBond in there so it gets a little bit more, you know, mushy if you want. And then you start inserting the crown. You press, remove the excess of bonding and composite mix, you press a little bit more, you press a little bit more, and you keep doing that until there is no more material coming through the margins. Right. At that point, I take a brush with the OptiBond and I kind of seal the margin around, and then you have a seamless restoration. The margins are, you know, because that technique, what also does, and I don't want to get too much into pros, but it corrects any interface discrepancy that you may have between the tooth and the crown. Right. I mean, up to 200 microns, people are saying that you can get it.
To compensate for that. I mean, it's kind of a reline, as we were talking about, right? Yeah. It is going to reline the whole crown for you. That's terrific, and I think, you know, as you look at all the literature, it seems like these types of chairside adhesive techniques work very well, but they're very time-consuming in order to do them right, which is kind of the reason why many people try to skip steps and do things and go alternative routes. But if one is willing to spend the time, and to that extent, I think it requires patients who appreciate that and then are willing to kind of compensate accordingly for the amount of time you spend chairside, these types of cases could work very well in the long run. And the case that you just showed, which I think 99.9% of people would have gone with a post-and-core and crown.
Or an implant.
Or an implant even, exactly, because some people would say there's not enough ferrule.
We have published papers and the evidence showing that, you know, in the 5 to 10 year range, there is a 2 to 3% lower survival rate than the regular crown post and core.
Wow, that's
but as you said, there is a lot of there are a lot of steps that they could be, you know, the adhesive technique, the preparation, the bonding, and all that. Now you also mentioned about time, and I think that once you have learned the technique, you save time. You know, because there's no need to prepare for a post and core. There's no need to, you know, rely on the crown. It's relatively fast once you know what you're doing, you know.
Well, terrific. I mean, this I think, I mean, there's so many other questions I want to ask, but I know you're busy and you have to go. I really want to thank you for spending the time here with us and showing these couple of cases that I think are going to be very instructive to our audience. And I'm sure we're going to get back together again and talk a little bit more about more specifics of some of these, as questions are probably going to come up. And I'd love for you guys to leave some comments below the video and questions that you may have for Dr. Galucci, and I can maybe do a follow-up. And and answer these questions for you. But in the meantime, once again, Dr. Galucci, thank you so much. The head of Restorative Department in Biomaterial Sciences, Harvard School of Dental Medicine, Dr. Galucci, joined me today. And once again, thank you so much.
Thank you, Ali. Thank you so much.
I'm Nasseh, this is Dr. Galucci, and until next video, let's save some teeth.